to prevent the symptoms and prevent the sudden cardiac death, as these is one of the common cause of sudden cardiac death. So one is lifestyle modification, as either we tell them just to avoid the strenuous activities, and drugs they should avoid dehydration, and drugs we should give the drugs which lower the contractility and increase the afterload and preload, and for SCD, ICD implantation and cardiac intervention. Next, please.
My patient underwent percutaneous transluminal septal myocardial ablation on 20th of June. Post-procedure, he developed first-degree heart block with right bundle branch block, which was managed conservatively, and repeat 24-hour Holter revealed normal study.
So we did PT SMA, alcohol ablation of the septum, and this was the during procedure. And we can see this is the trace. We keep a pigtail catheter in the LV and we take LV pressures. Here we can see these are LV pressures. And one catheter we keep in the aorta, just distal to the aortic wall. We can see this is the aortic pressure. So there is difference in the pressure of LV and aorta. So this is the gradient. So when we did the septal ablation, after that we got this type of hemodynamics. We can see here no gradient. So LV pressure reduced because initially there was obstruction at the LVOTO. When we did the ablation, so that obstruction get resolved and there was no gradient. So this is the post PTSMA hemodynamics. So basically, what this percutaneous transluminal septal myocardial ablation, what this procedure is, it is a minimal invasive procedure in which we do controlled myocardial infarction. So how we do it? We inject absolute alcohol 1 to 3 ml in any LAD branch, which are septal branches, which are supplying the septum, which is the thickest part and obstructing the LVOT. First, we do the angio. We see any septal branch. If there is any major septal branch, then we can inject alcohol very carefully because it should not spill over to LAD. It should just go into the, let's explain the procedure in later slides. So with that, there occurs myocardial infarction. So basically, this is the part which is obstructing the LVOT, which is Basil's part of the interventricular septum. So what pathological changes see in HCM? Basically, as we have seen in our case, there is gross hypertrophy of the ventricle and LV cavity size reduces very too small. And there are mitral valve abnormality as we discussed. And in this, we see histopathologically, then myocardial fiber generally they are placed in parallel position. But in this, they are placed in a bizarre shape. They are very random and there is this. So what pathophysiology, it causes what pathophysiology? First is left ventricle outflow tract obstruction, as we have seen in our, because of fever symptomatic. Then diastolic dysfunction, symptoms of heart failure with preserved ejection fraction. They can have PVH because there are increased ventricle compliance. With that LA pressure rises, with that pulmonary venous pressure rises, with which patient becomes symptomatic with breathlessness. Then third is microvascular dysfunction, as our patient had angina also. So coronary microvascular functions, dysfunctions. So mechanism of LVOT, if we see what is the mechanism, one is as such, because of thickened septum, here we see this is LVOT. From LA to blood comes to the LV, when it gets passes to the aorta, so there is obstruction. This is static obstruction, but because of this systolic anterior motion of this thing, anterior mitral leaflet, there occurs dynamic, as we said, triple ripple. So first jerky phase, then comes this phase during systole. During this phase, we feel the syncotic pulse, and with S4 during diastole, we get this force sound. So this is the mechanism of LVOTO. So what are the determinants? What what factors impact the left ventricle outflow obstruction? One is the increased contractility. So anything which is increasing cardiac contractility, like exercise, some drugs like dobutamine or any drug like digoxin. So if patient is taking those, they increase contractility. With that, force of contractility increases. With that, this dynamic obstruction increases, which leads to left ventricular outflow tract obstruction. Then things which decreases periload, because less ventricle is filled, then again it contracts forcibly and less blood is there. So there is again increased obstruction at the outflow and decreased afterload. Basically, decreased afterload increases the gradient because pressure distal to the aortic wall decreases and within ventricle increases. So when this gradient is there, which causes more increase in the degree of LVOT. With that, there is increased gradient and intensity of murmur. So principle of management, we already discussed symptom. We should control the symptoms. We should prevent the sudden death. Even we screen the family also. In case if we find any case with the HCM or HOCM, then we screen their kids, so that because it is an autosomal dominant, it is transmitted as autosomal dominant. So we screen the family also. Then there is septal reduction therapy, which we have already discussed in the form of PT SMA and surgical myomectomy. Then there are drugs which we use in HOCM like beta blockers. Then beta blocker, basically they decrease the contractility, decrease the heart rate. Basically force of contraction is decreased. With that, this obstruction is relieved. Then calcium channel blocker, again, they are also inductive inotropics. They also decrease the contractility and they relieve the obstruction. There are some other drugs also like disopyramide, which is basically antiplatelet drug. It has some anticholinergic effects. That is also useful, but one side effect is it prolongs the QT. That can also be used in case of increased outflow tract obstruction. Then we should avoid the drugs which increases the force of contraction of the heart. So these are drugs like digoxin. Then one should avoid diuretics because they decrease the preload. So with that, again, murmur will increase and gradient will increase and patient will become symptomatic. Nitrates, they decreases after load. So again, gradient will increase and that can cause the aggravation of symptoms. So septal reduction, we have already discussed alcohol septal ablation and myomectomy. Then there are some risk factors in HCM. When we are dealing with the case of HCM, definitely we should look for these factors, because these, if any factor, multiple factors add on, then there are increased chances of sudden cardiac death. So we should ask for the family history in the first degree relatives, massive LVH on echo or an MRI, then unexplained syncope. Then with systolic dysfunction, when there is a LV becomes dilated or systolic dysfunction or some apical aneurysm in the LV, or on MRI, there is late gadolinium enhancement, more than 15% VVC LG, and repeated runs of NVCT, NSVT, non-sustained ventricular tachycardia on Holter study. So all these are risk factors. So there is a online calculator available for this thing, just to risk stratify. And accordingly that we can plan for primary prevention for as a ICD we can use for prevention, and secondary prevention when patient is having ventricular tachycardia, then we put ICD. So this is the few slides of the procedure. So we can see here we did the angiogram. This is the left side angiogram. Here, this is the LAD and this is the septal branch. Here is the pigtail, which is in the LV. So this is just to take the LV pressures, and one more catheter we keep here just to take in the aorta, just to see the pressure. So our target is just to ablate this septal, this septal branch. So we put our TPI because these patients can have bradycardia, RBB, LVB post procedure. So we keep this thing, temporary pacemaker in situ. And then we take a wire, we place the one wire in LAD, one wire in the septal branch. And we took a over the wire balloon. Here, if you see, we take a balloon here in the septal branch and we occlude this septal branch. So in this, we can see just we occluded the branch. Then we injected the contrast. We are seeing here no contrast is going into the septal branch. Then we take out the wire. This is basically over the balloon. There is lumen in this shaft of this balloon. So through that, then we inject the contrast. We see that there is no spillage from the spillage of contrast into the LAD. Here we injected. After that, when we ensure that now this will go in this area only, then we inject the absolute alcohol. Here we are injecting the absolute alcohol in the septal branch. So our aim is to occlude the septal branch. So when we injected, so we take a run of LED also, so that there should not be any spillage, any obstruction or this thing in the LED. So here we can see we have taken out the wire of the septal, and we can see there is no contrast now going into the septal branch. Here we can see clearly. So we have, it just goes here till the where we have kept the balloon. So no flow beyond this point. So with that, we ablated, as we have seen in the hemodynamics only, pressure gradient was initially it was around 60-70 of pressure gradient, which was invasive gradient. And with this procedure, that gradient get resolved. So aim of today's presentation was to this HOCM is a common entity. Even we are finding in our large number of our serving soldiers, and we should do clinical examination in a proper way, and we can diagnose it clinically with some evidence on ECG also. Then we can do later on. And it is the important cause of sudden cardiac death in young, basically in athletes or the person who are doing strenuous activity. So after diagnosing this, we can prevent this sudden cardiac death. And this is very important for all of us, because in armed forces, we are dealing with the young soldier in which more chances of sudden cardiac death, and they are physically active. So we should be careful in diagnosing this entity. Thank you. Any questions and comments? From the resident? From faculty?
Morning, Balwinder. It was nice to see you bring a case which is clinically so relevant. I think just one or two points. And the first point which I want all residents, whether you are physicians, surgeons, or nursing officers, is that syncope, pre-syncope is a very important hemodynamically significant symptom. Don't disregard it. So if a person comes to you with dizziness or fall, please consider it as a very important symptom, because that means hemodynamics had failed. It's like flying an aircraft and suddenly your engines go off. It is that significant. So please be very, very careful when such patients come. Most of the time we think, no, it's just a young soldier, dehydration ho gaya hoga. Yeah, you were running a BPT and you had it. Don't. So symptoms of syncope present, and you then build it up. The second, of course, is that the clinical diagnosis in majority of the cases, and every week we get him together here, is the key. Please use a stethoscope. If you hear anything abnormal, go on to do it. But you'll first have to use a stethoscope. You first have to examine. So please do examine. This patient took some while to get to us. It took him 6 symptoms. It took him 4 years of breathlessness to be diagnosed. That's not a fair call. So those are the major, I would say, clinical implications of this case, that he's been symptomatic. He's serving soldier. He's been doing his medicals for the last 6 years. And it takes us so long to treat him. So that's probably the most important message I want to give. Anything from you, sir? Thank you so much, Balwinder.
Thank you, sir. Thank you, sir.